Please remain seated as we prepare the stage for part 2 of the session. Please turn your attention to the screens for a brief video.
We gratefully acknowledge the participation of the following organizations whose generous support makes this summit possible. We thank the Milken Institute's strategic partners for their year-round support of our work around the world.
Please welcome to the stage Director of the Centers for Disease Control and Prevention, Mandy Cohen, in conversation with CNN medical correspondent Meg Terrell.
Bright up here. All right, hi everybody. I'm so happy to be back here. It's nice to see everybody, and thank you so much to Dr. Cohen for joining us this morning. I think I want to start kind of where things left off with Rob. We're heading into a transition. How are you feeling about things? How are folks at the CDC feeling about things?
Well, I think Rob said it well. When public health is working, it's invisible. We like to be out of the news, and we're in the news a little bit. And so what I've been sharing with my team is that an election happened, but our mission hasn't changed one bit. CDC exists to protect health and improve lives. We're going to stay focused on that mission, and folks fundamentally, I believe, want their families to be safe, want their families to be healthy. And we need an entity like the CDC, as well as our larger public health ecosystem, to protect folks' health every day. And we've been working hard to be a different CDC. We are. 4 years has been really important for the CDC to learn some very important lessons, and we've taken action on those. And so I've told our team, stay focused on the things that we have been prioritizing, making sure we are ready to respond to any health threat coming our way. We've prioritized improving mental health in reaction to exactly what we were seeing in those polls, and supporting young families and making sure we're preventing and not just reacting to those health threats.
Tell us about some of those changes within the 4 years that you've made. What have you prioritized since you've been there trying to change at CDC?
Well, I've only had the baton for about 18 months, but in that time, we've really focused on making sure that we were ready to respond. Again, learning some tough lessons from the pandemic, and that certainly has made sure that we're putting in fundamental infrastructure that allows us to respond, whether that is the upcoming winter virus season, we're going to see more COVID and flu and RSV, or it's avian flu, or Mpox, or Marburg, or Lassa, right? Whatever we see, we'll be able to respond. So, for example, 3 things we didn't have 4 years ago. One, we did not have a national wastewater infrastructure 4 years ago. That got built during COVID and has since been utilized to look for avian flu, to look for Mpox, right? So we have a new asset that allows us to detect disease threats that we didn't have before. Second, we have the ability to see in real time what's happening in 90 to 95% of our emergency rooms. Something, again, we did not have 4 years ago. De-identified ability for us to see right here in a census tract level how many people get conjunctivitis in the emergency room, or how many people are getting a stomach flu, or how many people are coming in with chest pain. So those kinds of signals allow us to respond quickly. And then the third, particularly for this audience, we've really expanded our partnership with commercial laboratories across the country. We have very strong public health laboratories, but we all saw during the pandemic our ability to scale up laboratory capacity was critical. And now we want to make sure we have that warm capacity waiting for us if any health threat comes around the corner. So we have been partnering very differently with our commercial labs, not just to develop diagnostic tests from the beginning, have warm surge capacity, but also to ingest, again, de-identified laboratory data that makes us smarter and faster at identifying threats. So again, we're a different agency than we were 4 years ago. So coming in and saying that nothing has changed or everything, right? Take a look, we're different, and making sure that we are not going backwards from where we come.
You know, in conversations I've had with folks around the election, people in public health are really worried about the CDC and its ability to keep doing a lot of those key functions, those monitoring, communicating about vaccines. How much of what CDC does is going to chug along sort of regardless of what's happening at the broader political level, and how much could potentially change?
Well, I think, like I said, fundamentally folks want to make sure that we have an entity that is ready to respond to health threats, and that means we need data infrastructure to be able to identify those things, have the people who are talented to understand how to respond. But I do think that Rob said it well, there is a difference between understanding the evidence and the data and policy choices. And I think particularly when we look at resources, I think that is where I'm most concerned, because this kind of work and that infrastructure takes resources and you need to maintain it. Now, we already knew we were going to hit a bit of a cliff in the next coming year to 2 years as COVID funding goes away. And so there was already going to be a choice, but I am concerned when I see proposed budgets out there that zero out our ability to work on overdoses, on suicide. What do you think is killing people under the age of 50? Top reason is unintended injury, right, which is a combination of suicide, overdoses, car accidents, and for children, the number one thing that is killing our children is drowning, right? So if we are drowning our young kids, right, 2 to 5, right? So if we have to work on those issues, we need the data and the evidence and the investment in those areas. But the good news is, in the last 4 years, we've been making progress on overdose. And actually, you're going to see some new data from the CDC today about overdoses and continued progress in that space. So we've had our first reductions in fatal overdoses that we have seen, and we need to keep progress on that. So we are concerned, again, about having those ongoing resources to do this important work, to highlight the problems and the challenges, and then bring the evidence to solve those challenges.
And just to focus on that fatal overdose, those statistics, I remember it was just a few weeks ago we saw sort of the first hint of that, and I think some of the researchers were like rubbing their eyes, like, is this real? And they were trying to interrogate the data and see if it was, and it looked like it really was real. Do you have a sense of what is driving that finally to turn the corner?
Yeah, so a few months ago it was about a 2% decrease, and it was a 13% today. I don't want to get ahead of my team, but you'll see a further increase announced today. And so it is a real trend, and that's great. Look, we are throwing a lot at this, and we are starting to really break through, I think, with some important things. One, we know connecting folks to care at a moment of a non-fatal overdose is really critical, right? Because folks have had a major life event happen, they've almost lost their lives. It is the important time to connect them to care. We're using way more peer supports to do that. We are much more, talking much more about fentanyl and making sure that folks understand that fentanyl could be in things that you don't think fentanyl could be in, and so using things like fentanyl test strips, that is common language in our high schools. Unfortunately, we had to be there. So those are the kinds of ways in which we are highlighting it. I mean, and this work has been going on for years, and I want to shout out North Carolina, which is where I did work before I was at the CDC. Our new governor, Josh Stein, this was what he championed this issue, and I know we'll continue it, but it is that kind of focus. But this is what I mean. You have to maintain it, right? You take your eye off this ball, you take your resources away from this, and this can get away from us.
Well, I know an area that a lot of people are worried that could happen is bird flu. We just got some new information this week from Canada, a teenager there. It's one case, but it is a more severe case than we've been hearing about in the most recent cases in North America. This teenager was hospitalized, is in intensive care, has acute respiratory distress syndrome, was previously healthy. They don't know the source of the exposure. How much does a case like that change the risk assessment for you guys? And sort of how are you looking at bird flu and its threat right now?
Look, bird flu is something that CDC and the whole public health ecosystem has been thinking about for years. And so we have quite a mature mechanism of detecting and understanding it. Obviously, we've opened a new chapter in the avian flu front when we saw avian flu in our dairy cattle this year in the United States and in many states. But as you were saying, in the United States at least, those cases had been quite mild. Reassuring, but as we're saying, around the world when we see other cases of avian, it has been more severe. And so this case in Canada that came over the weekend, we have some more work to do to understand the strain of the virus. It is our presumption that it potentially is from one of the wild birds. It may look more like some of the avian flu cases we see often in Southeast Asia that tend to be more severe, but we don't know that until we can do the genetic analysis. But what we want to make sure, again, how do we think about any of these potential pandemic threats is making sure we have the infrastructure ready to go to be able to detect, to prevent, and to respond, right? And so we have a very extensive network of flu surveillance across the country. We are using, again, our wastewater infrastructure, brand new, wasn't here 4 years ago, to understand where avian flu is and the patterns, and allows us to do that genetic analysis. We do so much more genetic testing of samples than we've ever been able to do. But again, all of these things take resources, they take time to make sure our experts are working and focused on those things, so we have to keep up that vigilance.
With things like the wastewater monitoring infrastructure, if CDC were told to de-emphasize that, how much could that continue without involvement from the CDC?
Wastewater in particular. There are some wastewater sites that are supported in partnership with our states, but a lot of that funding, again, is braided together with some federal dollars, some state dollars. What's important about a wastewater infrastructure, again, it's looking for signals. You want to have that everywhere, right? You want to have a national picture of what that is, and so in order for it to be the most effective. And so we could see some of it continue again with state investment, but the vast majority of it currently is continued to be supported by CDC.
I want to ask you also about how you've approached communicating about public health. We see a lot of information coming from really disparate places. People are getting their health information from all over. We saw some of that in the presentation earlier. How has CDC responded to that to try to make sure people are getting good, solid health information?
Well, look, CDC had to get a lot better in the last 4 years on our communicating. It did not meet the moment, and I think we've really worked hard to make sure that we are different. First, we archived 60% of what was on the CDC website so that everything that was on there was more easy to find and understand. We've really changed our way we're thinking about our language. We're making things more common sense, actionable. What does this mean for my family? So instead of having COVID information over there and flu information over there and RSV, we put it together because people just get sick in the winter. They don't have a sign on their forehead that says I have COVID, right? They have to figure it out. I'm sick. What does this mean? What's going on in my community? And it's also giving our partners in healthcare the tools that they need to help better differentiate between some of these health threats and prioritize. So I think we have learned a lot of lessons in our communicating. We're trying to get data out more quickly. Overdose is a good example where we're able month over month to give provisional data that we then can validate over time. But even that quick provisional data allows people to take action, right? Data is only as good as the action you can take from it. And so I think we're getting a lot better, but we got to keep doing that work as we go forward. And and that is what we need to stay focused on as we get into this transition.
And we don't know what the next health leadership is going to look like. We have heard a lot about Robert F. Kennedy Jr. potentially taking some kind of czar-like role over health agencies. He tweeted in March that he wants to clean up the cesspool of corruption at CDC and force the public health agencies to come clean about COVID vaccines. He's also said that he wants to require there to be long-term placebo-controlled trials run on all childhood vaccines recommended by the CDC. What is your message to people working in public health about how to respond to that kind of language?
I think we have a very short memory of what it is like to hold a child who has been paralyzed with polio, or to comfort a mom who's lost their kid from measles. And it's not that many generations ago, but it is far enough away that folks have forgotten. And we need to remember that the reason we have these childhood vaccines is to make sure that we are the strongest, the healthiest that we can be as a community. And I don't want to have to see us go backwards in order to remind ourselves that vaccines work. They work, they protect our kids, they're our best defense against these terrible illnesses that luckily we haven't seen, but we are starting to see around the world because vaccine rates post-pandemic are lower. We're seeing more measles cases. Again, measles is one of the most contagious viruses out there. It's the canary in the coal mine for vaccination rates. We're seeing more measles cases here in the United States, but luckily more than 90% of our communities are vaccinated. That protects us. But remember that vaccines only work well when we are all getting to that, we've heard those terms, herd immunity, when we're all in this together, because we know that some folks whose immune systems don't work as well as others, their vaccines are not going to protect them. So they don't have the kinds of choices that some of us do have. So I think the important part in this moment is to remember to make sure that we're focused, as Dr. Califf said, on the evidence, and that we stay focused on what works to protect the health of communities. No one wants to see a child paralyzed, a child die from something that we can prevent.
And how do you respond to sort of charges that there are these troves of hidden data that the CDC has not released about vaccine safety?
Look, CDC has been incredibly transparent with information and data, and I'm really proud of that transparency. And so, we want to make sure folks feel reassured about vaccine effectiveness, about vaccine safety, and I think that's what folks are going to continue to see.
And looking back at your time at CDC, just more broadly speaking, can you give us what's been a high point for you and what's been a low point for you?
The high point has been traveling around the country. I have been on the road, if anyone follows my Instagram. I've been on the road and around the globe to see the work that we're doing. And again, Rob was so right here. When public health is working, it is invisible. And so what I've been trying to do is make that invisible visible to folks, to tell stories, to highlight those. So that's really been a highlight. Hard part is when I think folks are using memories of maybe past CDC, where again, we had to learn some hard lessons, and not acknowledging like the work and the progress forward. But that's why I'm here today, to remind everyone that we are a different CDC going forward, and that I hope to make sure that I'm passing the baton to someone who's going to take it and run forward, because I think we're focused on exactly the right things: being ready to respond, improving mental health, protecting our young families, and I think we need that not just for the health security, but frankly, we've all learned for the economic security of our country, that we can have our economic security turned upside down by a small little virus. And so I'm heartened by what I see across the country and the collaborative work, but we're going to need healthcare and public health to continue to be closer and closer together. I spent a lot of time in the last 18 months thinking about how to plug public health into healthcare. It was way too siloed, and it cannot be. We are one team here, and so whether that's in our data exchange, the way we think about treatment and diagnostics, the way we think about access, when we say population health over here and health delivery, which is more my area of my career, or we say public health over here, like, it's the same thing, and we have to be making sure we're working together as one team. There's just not enough time or resources in the world to be siloed.
And what's next for you?
Oh, what's next? Well, I'm focused on the next 60 days and making sure I'm leaving CDC in the best place possible. But I'm excited for the next challenge, which is continuing to make sure that we have healthy communities all across the country. I don't know what form that will look like. Maybe I'll be sending my resume out to you. But I look forward to continuing to impact health all across the country.
All right, Dr. Mandy Cohen, thank you.
Thanks, everybody.